Welcome back, guys. Now, after discussing about the actions of insulin, now in this video, let's discuss about the diabetic ketoacidosis. Before discussing about diabetic ketoacidosis, that is DKA, now a small topic, that is the regulation of insulin release. Okay, in which conditions insulin is released and in which conditions insulin release is decreased, that we will discuss now. Okay, so the conditions in which the insulin release is going to be increased and the conditions in which the insulin release is decreased. We will see one by one. See, what are the powerful stimulus for the release of insulin? The stimulus for the release of insulin is glucose itself. Okay, so glucose itself is the most potent stimulus. Okay, it's the most potent stimulus for the release of insulin molecule. You have taken the food is digested, now glucose molecules are released, and now this glucose will enter into the beta cells of pancreas, will stimulate the beta cells of pancreas to release more insulin. Okay, so glucose is the most potent stimulus. After this, let's talk about one more important substance, that is the glucagon. Okay, so glucagon is also important stimulus for the release of insulin. See, usually students think like this: insulin, it decreases the glucose, glucagon increases the glucose. So insulin and glucagon, aren't they antagonistic hormones? Yes, they are antagonistic hormones. But think logically. See, whenever there is glucagon in your blood, what will happen? Glucagon, see here, glucagon. What it will do? Glucagon is going to increase the blood glucose levels. Now, whenever you have increased blood glucose levels, whenever your blood levels of glucose is increased, now you need which hormone? You need insulin. So that's why glucagon will directly stimulate the release of insulin. Why? Because yes, glucagon knows, whenever there is glucagon will increase the glucose and you need to take the glucose into the cells. For that purpose, you need to have the insulin. So that's why glucagon gives positive feedback for the release of positive signal for the release of insulin. So glucose is a potent stimulus, glucagon is also a stimulus, and other stimuluses includes amino acids. Amino acids, especially arginine, leucine. Okay, so arginine and leucine, these are the amino acids which will also give the positive signal for the release of insulin. Why? See, insulin is an anabolic hormone. Insulin is like helping in protein synthesis in the body. So when you take the food is digested, now these amino acids are getting released, now these amino acids will stimulate the release of insulin. So insulin will cause the protein synthesis in the body by utilizing these amino acids. Okay, by utilizing these amino acids, new proteins are synthesized. Okay, so these amino acids will give positive signal for the release of the insulin. Not only that, even long chain fatty acids. Long chain fatty acids. So long chain fatty acids also gives the stimulus for the release of the insulin. So in these conditions, whenever you have increased long chain fatty acids in the blood, or whenever you have amino acids in the blood, glucagon, glucose, all these are going to give the stimulation for the release of insulin. Now apart from them, one more, parasympathetic activation. Parasympathetic nervous system or parasympathetic activation. So we all know parasympathetic nervous system will be activated. The parasympathetic nervous system will be activated whenever there is whenever the person is taking the food, whenever the person is relaxed. During that conditions, parasympathetic nervous system is activated. So you take the food, parasympathetic activity is there. Now parasympathetic activity will increase all the GI hormones. Okay, will increase all the GI hormones, also the insulin. Why? Because the person is eating, his blood glucose levels are going to rise. Whenever his blood glucose levels are going to rise, we need to shift the glucose from the blood into the tissues. So for that, we need the insulin. So parasympathetic activation, okay, or vagal stimulation, or by releasing the acetylcholine onto the pancreas, more insulin molecules are released. So these are some important stimulus which will increase the insulin release. Now let's talk about the condition where insulin release is decreased. Okay, let's see one by one. First thing is somatostatin. Okay, or somatostatin analogs like octreotide. Okay, octreotide, lanreotide drugs. So somatostatin, it decreases everything. It decreases insulin, decreases glucagon, it decreases acid, decreases the growth hormone, it decreases everything. So somatostatin is the one drug which will decrease the release of insulin. Apart from somatostatin, drugs, especially the stimulus for the alpha 1 receptors, alpha 1 adrenergic receptors, alpha adrenergic receptor stimulation. Okay, alpha adrenergic receptor stimulation can decrease the insulin release. Try to understand like this. See, the alpha receptors or the adrenergic receptors are sympathetic receptors. Whenever the sympathetic activation is there in your body, okay, whenever the sympathetic activation is there in your body, you need to fight or flight away from that region, right? You need to fight or flight away from that region. If you want to fight or flight away from that region, you need more glucose in the blood, okay, you need more glucose in the blood. If you want more glucose in the blood, what should happen to the insulin? Insulin should go down. So sympathetic activation will actually decrease the insulin so that the blood levels of glucose will be more. So by using that glucose, either you will fight or flight away from that situation. So alpha adrenergic receptor stimulation will decrease the insulin release. Okay. Now, apart from that, what else will decrease the insulin? See, it's the hypokalemia. Conditions of hypokalemia. Okay. So the conditions of hypokalemia will cause decrease in insulin release. See, when we are discussing about the release of insulin, the topic of release of insulin, I have clearly explained you that it's the potassium accumulation inside the cell which will cause the depolarization of the beta cells of the pancreas. The potassium accumulation inside the beta cells of pancreas will cause a depolarization of the beta cells. So depolarization will ultimately lead to the release of the insulin. But when you have hypokalemias, potassium levels is less. What will happen? When your potassium levels are going down in the beta cells of pancreas, the cell is hyperpolarized, it is inactivated, it is not releasing the insulin. So conditions of hypokalemias or conditions leading to hypokalemias will decrease the insulin release. Okay, so can you tell me one drug which decreases the potassium, which depletes the potassium from the cell? It's a diazoxide. Okay, diazoxide. Okay, so what is diazoxide? Diazoxide is a potassium channel opener. It will cause potassium depletion inside the cell. So the cell will be undergoing hyperpolarization or inactivation. Okay, and apart from that, even drugs like thiazide diuretics. Okay, drugs like thiazide diuretics. Now, even not only the thiazide diuretics, even the loop diuretics also. See, these thiazide diuretics and loop diuretics, what kind of drugs are they? They are potassium wasting drugs. Okay, they will cause potassium excretion out of the body. They will take the potassium out of the body. Okay, they are potassium wasting diuretics. The one potassium sparing diuretic which we all know is the spironolactone. But here, see, loop diuretics, thiazide diuretics, what they will do? They will take the potassium out of the body. They will cause hypokalemia in the body. Whenever there is hypokalemia, automatically insulin release will be decreased. So even diazoxide will decrease, and a few more important drugs worth mentioning like phenytoin. Okay, an anti-epileptic phenytoin and streptozocin. These are the drugs which will decrease the blood glucose, not blood glucose levels, which will decrease the blood insulin levels, which will decrease the insulin release. So in this slide, I have discussed some of the important points where the conditions where the insulin level is increased and the insulin levels are decreased. Okay. Now after this, let's talk about the conditions or the hormones which increase the blood glucose levels and the hormones which decrease the blood glucose levels. We all know that insulin decreases the blood glucose levels. Okay, well and good. But which hormone increases the blood glucose levels? Okay, see, even before the endocrinology, you guys know only one thing. So glucagon increases the blood glucose levels. Okay, glucagon increases the blood glucose levels. Insulin decreases the blood glucose levels. You know this one point. But see, it's not just the glucagon. Okay, we have discussed in the topic of growth hormone. See, growth hormone increase the blood glucose levels. In the thyroid topic, we have discussed thyroid hormones increase the blood glucose levels. Later, in the upcoming videos, we will discuss cortisol increase the blood glucose levels. And even sympathetic hormones, catecholamines, fight or flight, you need more glucose in the blood. So, glucagon, growth hormone, thyroid hormones, cortisol, which is a stress hormone, and catecholamines, epinephrine, norepinephrine, dopamine, these are the hormones which will increase the blood glucose levels. They will increase the blood glucose levels. Okay. So, after this, let's talk about our main topic, that is the diabetic ketoacidosis. Okay, DKA. Now see, this condition, diabetic ketoacidosis, everything is in the name. The patient is diabetic. Okay, diabetic ketoacidosis. The patient is suffering with ketoacidosis. Ketone bodies are getting produced in the body. Ketone bodies are acids, so that's why acidosis is there. So diabetic patient generating the ketone bodies inside his body, and these ketone bodies are decreasing his pH, leading to acidosis. Okay, ketone bodies are acids. Okay, now let's put it up in a story. First, let's begin our story with, see, this diabetic ketoacidosis. It is seen, okay, it is seen in type 1 diabetes or type 2 diabetes. It is seen both in type 1 as well as type 2 diabetes, but mainly it is seen in type 1 diabetes patients. Now tell me, what is the problem with the type 1 diabetes mellitus? Okay, type 1 diabetes mellitus. What is the problem? There are two types of diabetes, right? Type 1 as well as type 2. In type 1 diabetes mellitus, there is autoimmune destruction of the beta cells of pancreas. Okay, it's the autoimmune destruction. Autoantibodies are destroying, okay, they are destroying the beta cells. Now the beta cells of pancreas are destroyed. So what happened to the insulin? Insulinopenia. Insulin levels are decreased. So there is insulinopenia. Okay, insulinopenia, which means the insulin levels are decreased inside the blood. Okay. Now what is type 2 diabetes mellitus? Okay, type 2 diabetes mellitus. So in type 2 diabetes mellitus, the problem is, okay, the problem is in type 2 diabetes mellitus, insulin resistance. Insulin resistance. Insulin is there, okay, there is no problem with the insulin. Insulin is there, but resistance, the insulin receptors are not properly getting stimulated. Okay, insulin resistance is there. So now let's stick to our topic, that is diabetic ketoacidosis, which is mainly seen in type 1 diabetes mellitus. What is the problem in type 1 diabetes mellitus? The autoantibodies are destroying the beta cells of the pancreas. When the beta cells of pancreas are destroyed, there is insulinopenia, less levels of insulin, or insulin deficiency is there. So insulin deficiency is there. Now whenever there is insulin deficiency, now glucose from the blood will be moving into the tissues? No, tissues cannot utilize the glucose. If there is no insulin, tissues cannot utilize the glucose. Normally insulin should have to act on the tissues, should have to make the glucose transporters type 4 in the cell membrane, then only the glucose molecules entering into the tissues. Then only the glucose molecule will be transferred into the tissues. But right now what is happening? Because of the deficiency of insulin, the tissues cannot utilize the glucose. Glucose is there, remember, glucose is there in the blood. There is no problem with the glucose. The person is eating, he is having enough amount of glucose. Actually there is hyperglycemia is there, but tissues cannot utilize. Now what tissues are thinking? Tissues are thinking that there is no glucose. That's why glucose is not coming into the cell. But problem is, glucose is there, tissues cannot utilize it. Now in this condition, what tissues will do? Tissues will think, okay, glucose is not there. So now tissues will try to increase the blood glucose. Okay, tissues will try to increase the blood glucose by certain methods. What is that? See, tissues are unable to utilize the plasma glucose. Now what happens? See, counter regulatory hormones are produced. Tissues are thinking there is no glucose. So tissues are producing what? Now tissues are producing growth hormone. Okay, now the counter regulatory hormones are produced. Growth hormone is coming. Okay, and growth hormone is coming. Cortisol, epinephrine, glucagon. All these counter regulatory hormones are released. Why? See, all the hormones which I am discussing here, glucagon, epinephrine, cortisol, growth hormone, all these hormones are the hyperglycemic hormones. They will come and they will increase the blood glucose levels. Okay, now see, they are coming, okay, and they are increasing the blood glucose levels. But is there any solution for the problem? No solution. Already glucose is there. Now these counter regulatory hormones are produced. They further increase the blood glucose levels. They too much increase the blood glucose levels, but still the tissues cannot utilize the glucose. The tissues cannot utilize the glucose. Okay. Now what is happening? See, there is excessive amount of all these counter regulatory hormones. What they are doing? They are acting on the liver. See, they are acting on the liver. So the glycogen in the liver. See, the glycogen in the liver will be broken down, releasing the more glucose molecules. See, more glucose is coming by the process of gluconeogenesis. Okay, by the process of gluconeogenesis, still more glucose is getting produced, but the glucose cannot be utilized by the tissues. Now what happened to all this glucose? See, all this glucose is now going to the kidneys. Okay, now kidneys are having certain capacity to reabsorb the glucose. Okay, normally in you and me, our blood glucose levels are how much? The plasma glucose levels is 100 milligrams per deciliter. Just take a round figure, 100 milligrams per deciliter. Now the person is having 300 milligrams per deciliter, 400 milligrams per deciliter. So much glucose is there. Now all this glucose will be freely filtered. Okay, glucose is freely filtered in the nephrons. But in you and me, all the glucose will be reabsorbed in the proximal convoluted tubule. 100 out of 100% of the glucose will be reabsorbed in the PCT. But in this person, the filtered load is more. More glucose is getting filtered. Why? Because more glucose is there in the plasma. Now, do you think all the glucose will be reabsorbed? No, all this glucose is not reabsorbed. Now glucose will start to come out in the urine, causing glucosuria. Remember, glucose is a osmotically active substance. Okay, it's a osmotically active substance. Wherever sodium goes, water follows. In the same way, wherever glucose goes, water follows. Now, this person who is having diabetes, now he is losing lots and lots of glucose in the urine. So, along with the glucose, more urine is going out. So, that's why diabetic people will have polyuria. Okay, even diabetic ketoacidosis patients, now their blood levels of glucose is more, all this glucose is going out in the urine. So, that is causing excessive urination, polyuria. This polyuria will cause dehydration. The person is getting dehydrated, his mucous membranes, all they are getting dried. Okay, dried. So there is dehydration. The dehydration will cause the thirst. Now he is feeling like, he have to take the water. Thirst. That is polydipsia. So polyuria followed by polydipsia. Polyuria causing dehydration, dehydration causing polydipsia. Okay, so these are the problems. Okay, because of the osmotic diuresis. Osmotic diuresis is happening. Glucose is taking out all the fluid out of the body. So this is half of the story. Now tell me, a diabetic ketoacidosis patient. So far there is no ketoacidosis. So far, what is the problem in diabetic ketoacidosis? It's the excessive urination and dehydration. Okay, excessive urination, dehydration is a problem. Now, at the end of the day, is there any solution for the problem? Tissues, are they able to get their energy source? No, glucose is not going into the tissues. Now, what tissues will do? Now, tissues will take this fat. The fats are getting broken down. Okay, lipolysis. Insulin inhibit the lipolysis, but whenever there is no insulin, lipolysis is happening. So now the fats, okay, are getting broken down. Lipolysis is happening, leading to the generation of fatty acids. Now these fatty acids, they will go to the liver in the mitochondria of the hepatocytes. In the mitochondria of the hepatocytes, by using these fatty acids, okay, by using these fatty acids, ketone bodies are generated. Okay, ketone bodies are generated. If you ask me what are these ketone bodies are also energy rich substances. Ketone bodies will be converted into acetyl coenzyme A with which energy is generated. Okay, so fatty acids, yes, it will go to the liver now. Now in the liver, ketone bodies are produced. Now what are the examples of ketone bodies if you ask me? Okay, now the examples of ketone body include acetone. Okay, acetone, beta hydroxybutyric acid. Okay, this is beta, okay, not just B, beta hydroxybutyric acid, and as well as acetoacetate. These ketone bodies are getting generated. So in a patient who is suffering with diabetes, ketone bodies are generated. If you ask me why ketone bodies are getting generated? Why? Because, see, remember, insulin inhibits the ketogenesis. Okay, previously also we have discussed, see, insulin, what it will do? Inhibit the ketogenesis. But whenever there is deficiency of insulin, whenever the insulin is not there, what happens? Ketogenesis is activated. Okay, ketone bodies are produced. Now see, these are the ketone bodies. They are the acids. So if they are acids, they will cause acidosis. So diabetic ketoacidosis. Even in the topic of acid-base balance in the renal physiology, we have discussed. See, whenever you are having acidosis, what you will try to do? See, your buffers, okay, in the blood, your buffers, that's the bicarbonate ion, will try to neutralize the acids. And the lungs will try to regulate your pH. Your kidneys will try to regulate your pH. Now, whenever you have acidosis, see, okay, once you become doctor, once you just come to the practice in the clinic, now when you look at the diabetic ketoacidosis patient, he will be doing hyperventilation, something like that. Okay, he will be having deep inspiration as well as a deep expiration. Why there is deep inspiration and deep expiration? Because see, whenever I am having acidosis, I will be doing, my breathing pattern will be hyperventilation, deep inspiration, deep expiration. Why? How it is helpful? See, if I am having deep inspiration, deep expiration, carbon dioxide is going to expel out. Carbon dioxide is puffed out of my lungs. So what happened to the carbon dioxide concentration in my body? Carbon dioxide concentration goes down. Remember, carbon dioxide generates the protons in the lungs. Carbon dioxide reacts with the water, forms the carbonic acid H2CO3. H2CO3 splits into HCO3 minus as well as H plus. Okay, that H plus is the acid. It's a proton. It's an acid. Okay. So what I'm trying to put into your mind is, see, whenever you have this acids in your body, acidosis in your body, your lungs, okay, you are trying to do the hyperventilation to take out the carbon dioxide, to decrease the acid production. So such a type of breathing is called as Kusumal's breathing. See, okay, such type of breathing is called as Kusumal's breathing. Kusumal's breathing is nothing but the hyperventilation seen in diabetic ketoacidosis patients. So Kusumal breathing is seen. And these keto acids, especially acetone, okay, acetoacetate, this acetone. Now this acetone, it is having a sweet smell. Okay, it is circulating in your blood, right? It is circulating in your blood. These ketone bodies are utilized by your brain, heart, skeletal muscles, adrenal cortex. Okay, everything. Okay, most of your body cells will utilize these ketone bodies except the erythrocytes. Erythrocytes cannot utilize the ketone bodies. That's a very important MCQ. Okay, so ketone bodies are not utilized by the erythrocytes because erythrocytes do not have the mitochondria. So ketone bodies are not utilized. But anyway, these ketone bodies are present in the blood, and these ketone bodies will give rise to a characteristic smell called as sweet breath. Okay, sweet breath. Okay, done. And these ketone bodies, okay, what they are causing? They are causing acidosis. Okay, they are causing acidosis. Now, whenever there is acidosis, what happens is, okay, whenever there is acidosis, or I should say, in a simple way, previously we have discussed insulin. What is the action of insulin? Insulin will move the potassium ions into the cell. Okay, till the time you have insulin, potassium is packed inside the cell. Now our problem is what? Insulin deficiency. Whenever there is insulin deficiency, potassium is not going to stay inside the cell. Potassium will come out of the cell. So, see, more potassium will come into the cell. That will cause hyperkalemias. Not only that, even sometimes there will be hypokalemia. So, both hyperkalemias as well as hypokalemias are seen in diabetic ketoacidosis. No one will ask you, but what they will ask you is, see, insulin is not there. So, potassium abnormalities are seen. Potassium abnormalities are seen as a consequence or as a complication of diabetic ketoacidosis. Okay, no insulin, potassium will start to come into the cell. Come out of the cell. Okay, so it will lead to the potassium abnormalities. So, with this, we have seen the pathogenesis. What exactly happens in diabetic ketoacidosis? Now, tell me, what is the treatment? Okay, what is the treatment done for the diabetic ketoacidosis? All problem begins with deficiency of insulin. So, the treatment is just give insulin, that's it. Just give insulin. So, treatment is insulin. Okay. Now, what else? These patients are suffering with dehydration. Okay, so hydrate this patient. Also try to maintain the electrolytes. Okay, also give the electrolytes. Why? Because electrolyte abnormalities are there, right? Especially potassium abnormalities are seen. So, why you are giving insulin? Insulin decreases the ketogenesis in the liver. Some important MCQs. See here. A 50-year-old man presents it with the DKA. Okay, he was started on IV insulin therapy. He is at risk of developing which abnormality? Now see, he is having diabetic ketoacidosis. Now what you have gave? You have gave insulin. When you give insulin, what this insulin is going to do? Insulin will move the potassium ions immediately into the cell. So immediately you give the insulin, potassium will start to shift into the cells. That will cause hypokalemia. Okay. So after giving insulin as a treatment for diabetic ketoacidosis, you will have hypokalemia as a complication. Okay, and on administering insulin, which are the following events are first to occur? See, potassium influx into the adipocytes. Potassium will go into the adipocytes. Okay, now one more question which I want you to know is, see, what are the complications? Okay, what are the complications because of the diabetic ketoacidosis? And complication in the sense, most common cause of death. Okay, most common cause of death. The most common cause of death in a patient who is suffering with diabetic ketoacidosis is cerebral edema. Okay, the mechanism of cerebral edema is not well understood. Okay, cerebral edema, especially in children. Okay, especially in children, cerebral edema will cause death. So with this, we are done with the topic of diabetic ketoacidosis. Hope the video is helpful. Thank you.